Good evening and a warm welcome to all. Firstly, I would like to thank each one of you for registering and joining with us today for the Breast Cancer Masterclass. Now, I would like to welcome our program chair, Dr. Ashok Vaid, a top medical oncologist of the country, known for his pioneering efforts in bone marrow transplantation in India. He has conducted more than 40 international and national studies in clinical research. He is known for organizing numerous seminars, workshops, and conferences also. He heads the Medanta Cancer Institute, Division of Medical Oncology and Hematology at Medanta, the Medicity. Now, I would like to invite Dr. Vaid to give us a welcome address. Thank you. Over to you, sir.
Thank you, Priyanshi. And once again, request if people could mute so that the proceedings can go on uninterrupted. Very warm welcome to everyone on the program. Thank you, Priyanshi, once again. I have the honor and the privilege of welcoming all the guests out here, all the speakers, faculty, Dr. Akhil Kapoor, Dr. Kumar Saurabh, Dr. Sameer Srirangwar, and the panelists, Dr. Murtaza. Again, Akhil is going to be there, Dr. Chakor Bora, Dr. Sameer, and Dr. DG Vijay. They have taken time out to present, to be on the proceedings, and last but not the least, to deliver the take-home message, Dr. Meenu Walia. I thank all the participants. There are 324 registrations from almost about 25 countries and a lot of places, names one hasn't even heard of, sitting here in India. I welcome everyone on this program, and I hope the proceedings will give us a lot of learning, and we would have some of the practice-changing presentations, and they would help us shape our clinical practice of tomorrow. I have to thank Rajesh immensely, Priyanshi, for doing such a wonderful job, the team at the back end for putting all this program together, and also the driver and the sponsor of these programs, Samarth Pharmaceuticals, and Om Mishra, who's always so enthusiastic about all these master classes. And I would say these are the ones which are powered by him and his company. With that, I hand over the proceedings back to Priyanshi to take the scientific program forward. Thank you so much.
Thank you so much, Dr. Vaid, for such a wonderful welcome to all the faculties. Now, let us begin with our masterclass. And for the first talk, I would like to invite Dr. Akhil Kapoor. He is Associate Professor in Department of Medical Oncology, Tata Memorial Hospital in Varanasi, and he's going to speak on early stage breast cancer. Thank you, and over to you, sir.
Thank you, Ashok sir, for inviting me. I'll be starting with my presentation. Thank you. So hopefully everything is fine with the issue. Yeah. So directly I will start with some practice-changing trials which we have seen in the last year, and these are actually have changed the way we practice medicine in our practice. Let's see first about the Monarch trial. This is the trial about the adjuvant abemaciclib data, and definitely this is one of the important trials, especially in high risk node positive hormone receptor HER2 negative early breast cancer. If we see, this included patients who had received even neoadjuvant chemotherapy, pre or post menopausal, both were allowed in this patient study, and the patient should have less than 16 months from surgery to randomization. So this is a large time, less than or equal to 16 months. So around 1 year and 4 months, that is a long time. That is why we'll come to that. Sometimes which the patient is hormone receptor positive, and also patient is positive for BRCA1 and 2, then also this still merits, because sometimes physicians prefer to give adjuvant olaparib. In this case, after completing adjuvant olaparib, still you can start adjuvant abemaciclib. So that is an important implication of 16 months of surgery from the to randomization. And those patients, they were divided into 2 cohorts. if we see the cohort 1, which is the most important cohort, which actually is we see in our practice as well, patients having a high disease burden in the nodes, that is regarded as 4 or more positive axillary lymph nodes, or 1 to 3 positive nodes plus histologic, it should be grade 3, along with tumor more than 5 centimeters. So this is the cohort which is most important in our practice. The cohort 2, which comprises around close to 10% of the patients, that was 1 to 3 nodes positive. At the same time, the patient may have grade 1 to 2 tumor and tumor size less than 5 centimeter. But if they had Ki67 more than 20%, they were also included. So based on this has got approval for both the cohorts. But in our practice, we restrict mainly for this high nodal disease burden group in our routine practice. The patients were stratified for the menopausal status and received abemaciclib 150 mg BID for up to 2 years, along with the hormonal therapy, whichever the physician is comfortable with. And the second arm had a standard arm with endocrine therapy alone. And here, the primary endpoint was invasive disease-free survival. We see a lot of now trials, new trials with IDFS data. Why not OS or anything else? Just one word, because these patients have a long-term survival. And if we wait for the OS data, that will take at least a decade or 2 decades at least for getting the full data available. And this will deprive a lot of patients of effective treatment which is available. That is why these are some surrogate endpoints which are taken in such trials. So if we see the IDFS data, it is very clear. A 4-year IDFS rate with abemaciclib was 85.8% versus 79.4%. And this was statistically significant, with significant difference in the number of events in both the groups. And you can see even in hormone receptor positive, getting a absolute difference of 6.4% just 4 years is actually worth merit. And if we continue to follow up the data, it seems that the curve is continuously separating more and more, and this will help in getting much more difference in the later time. So definitely long-term data will be awaited, but this has already changed our practice. If we see the distant relapse-free survival, it is also very clear that within a short time, this has led to very significant reduced number of events. So abemaciclib number of events just 281 as compared to ET alone arm, it was 421, and this is highly statistically significant. And this 3-year data is also favoring all the subgroups of the patients. This is the OS data. Definitely it is mature, and we cannot have significant number of OS data at this point, because patients will receive CDK4/6 inhibitors even after having distant metastasis, and they will still survive. So that is in a point that OS will not show so much difference in the initial phase, and that the number of events are definitely somewhat higher in the ET alone arm, but it will take a very, very long time to get the OS data mature. Moving further, we see the cohorts. So as I told, that cohort 1, which was the maximum cohort, the maximum benefit is seen in those patients. Hazard ratio is to the tune of 0.65, while in cohort 2, the hazard ratio is to the tune of 0.7. Not too bad, but still cohort 1 seems to be the best cohort. If we see the by Ki67 status, you can clearly see patients who are having high Ki67, it seems that as high Ki67 is higher, the benefit will be higher. So and safety, and this is an important point. We have utilized abemaciclib a lot now in our practice. We have more than 50 patients on abema now, and we understand that though it was thought that diarrhea is very important side effect, but in real practice it's not so common in our patients. It might be different from the various ethnic groups, but our patients tend to tolerate it better, and just cautioning about diarrhea is fine, and they will tolerate the same. So mind dose adjustments were required. Now coming to rapidly to the next trial, which is another very important trial, neoadjuvant TDX trial. So this drug we are many of us have utilized now by importing it specifically in our metastatic patients. Now this is a trial of neoadjuvant TDXD plus minus anastrozole for hormone receptor positive HER2 low ABC. So this is another group, HER2 low ABC, and utilizing neoadjuvant TDXD along with anastrozole. You can see this is a dreamlike study where very effective drugs are being combined in low HER2 EBC. And primary endpoint in all these studies with neoadjuvant trials is actually PATCR, as we see even in the trial which was carried by TMH Mumbai, and you can see the PATCR rates difference. If you see the overall response rates, we have clearly see the TDXD arm, so huge number of patients having a lot of good responses, partial responses in a large number of the patients. So 70% patients are having responses. That is very good. And hopefully this drug will have this significant outcomes in HER2 low patients as well. HER2 positive, we know everywhere it is going to work, where it is neoadjuvant setting, adjuvant setting, or metastatic setting, but we have started to use already in MBC setting. This is the change in the HER2 IHC status. You can see the HER2 low, that is HER2, it was 1 plus or 2 plus with low FISH negative. It is changing this is so potent drug that it is completely devastating the HER2 receptors, and HER2 positive cells are completely being destroyed. And you can see the maximum patients are having reduction in the HER2 status expression itself. So that will be one of the way of resistance to this drug, we all understand now. And post 6 cycles, a lot of patients had close to near CR or path CR. And the safety, yes, we have learned how to utilize this drug. TDXD induced pneumonitis is one thing to watch about, but with time we have understood. And in the initial trials of TDXD, there were higher risk of pneumonitis, but later when we understand how to utilize it, the risk of pneumonitis had decreased because of the proper follow-up. We can do NCCT thorax after 15 to 20 days of the first dose to see whether it is causing significant pneumonitis or not, and later on we can adjust accordingly. Coming to further data of retrospective data, which is recurrence with central lymph node biopsy in node positive early breast cancer. So this is another data which was image guided localization of sample node versus dual tracer mapping, which is done by the central lymph node, a standard procedure which we do. It was the goal was to assess cumulative incidence of the recurrence in the nodes among the patients who had path CR with neoadjuvant chemotherapy. So that is actually to reduce the morbidity of the surgery by reducing axillary node dissection number, less number of nodes dissected, that will reduce the lymphedema rates, and that was the main target. And if we see the recurrence rates, it seems that there is no difference in 3 years between locoregional invasive recurrence between the two groups. So targeted nodal dissection versus central lymph node biopsy, it seems that both are doing similarly at 3 years. Long-term data is awaited, but yes, it is very important. If we see interrupting endocrine therapy in women who are attempting pregnancy, this is known as a positive trial. So it is actually a positive study, and this had a primary endpoint of breast cancer free survival from breast cancer free invasive disease survival. So premenopausal women of less than 42 years of age who had prior 18 to 30 months of prior adjuvant endocrine therapy for stage 1 to 3 hormone receptor breast cancer, and they were desiring pregnancy and wanted to interrupt the endocrine therapy. Up to 2 years of break was allowed to allow conception, delivery, and up to plus minus breastfeeding. So they resumed later after 2 years endocrine therapy to complete planned 5 to 10 years. And this is a very important study which we dream to carry in our routine practice, but we could never do such study. So there was 3 months of washout period was allowed and before enrollment, and you can see the breast cancer free interval was nearly similar. So it's a positive trial with or without interruption. It seems that there's not so statistically significant differences are arising in both the groups. That makes us believe that yes, this can be considered in patients who are desiring pregnancy, and it can be considered. And if we see the positive trials outcomes, 66% patient undergo the standard delivery, while 35% require cesarean. There were complications of hypertension, eclampsia, diabetes in around 10%, but this is the usual presentation. Nothing new and new addition or extraordinary complications were seen. And also the live births and any hormonal abnormalities, birth defects. These were to the tune of the standard ones, not any increased adverse effects. So this is also a point which we wanted to know, that there was no increased birth defects, there were no spontaneous abortions, and these were similar. So if we see the cumulative incidence of endocrine therapy resumption, 8% experience cancer recurrence prior to endocrine therapy resumptions, and 76% could resume endocrine therapy. So close to 80% of the patient who were disease free at 2 years had not yet resumed endocrine therapy, stating active or recent pregnancy, breastfeeding, or in pursuit of pregnancy. To summarize, the Monarch trial, it has IDFS and DFS benefit of adjuvant abemaciclib. Ki-67 remains prognostic, but not very strongly predictive of the outcomes. And abemaciclib benefit was observed regardless of Ki-67 status. In the Talent study, where neoadjuvant TDXD was combined with anastrozole, it was found that TDXD alone had response rate at 70%, and the anastrozole could have some small benefit. And this early axillary recurrence after omission of dissection was seen in very small number of the patients. Longer follow-up is needed for the same. Positive study, temporary interruption of endocrine therapy to allow for pregnancy allowed 75% of women to have pregnancy without any complication. Some had around 8% had recurrence during the time, but that is somewhat similar to the standard time. With this, I would like to stop here and thank you and greetings from Team HORANC. Thank you, sir.
Now let us move on to our next topic, which is HER2 positive breast cancer. And for that, I would like to invite Dr. Kumar Saurabh. He's consultant in Department of Medical Oncology, Shambhavi Center for Cancer. Thank you, and over to you, sir.
Thank you, Priyanshi, and thank you, Dr. Ashok sir, for having me here. Let me share my screen. So, it's is my screen visible?
Yes, sir, it is visible, but can you do full screen?
Yeah, done full screen. Is this okay now?
No, sir, we cannot see your screen, your full screen.
Not coming full screen. One second, let me try. Is this okay?
No, sir, still we cannot see the full screen. Sir, can we present it from our side?
Yeah, no issues. Please do so.
You can stop share. We'll present it from our side.
Yeah. Thank you, Priyanshi. So today I'm going to discuss about HER2 positive breast cancer. Can I have my next slide? Yeah. So we'll be discussing a few trial data, mostly regarding trastuzumab deruxtecan. Personally, I would like to share that I don't have any experience with drug because this drug is not available in India right now. But most of the trial data seems very promising, and I believe in near future we'll have this drug in India. So this is the Destiny series of trial. The first is Destiny Breast 02, where trastuzumab deruxtecan is used in HER2 metastatic breast cancer after progression on trastuzumab emtansine. Now, TDM1, as we all know, is a very good drug, and it's widely used after the introduction of generics, the cost has also come down. But after trastuzumab emtansine, after a HER2 positive breast cancer progresses on TDM1, we don't have many options. Most of us go for lapatinib, capecitabine combination, but it's not that effective. So let's see how trastuzumab deruxtecan fits in that particular setting. So this trial was designed to have two arms. One arm, the patients with HER2 positive metastatic breast cancer after progression on TDM1 were randomized to either trastuzumab deruxtecan versus physician's choice, which included mostly either trastuzumab capecitabine or lapatinib capecitabine. And the primary endpoint was PFS. The secondary endpoint was overall survival. And other secondary endpoints were ORR, duration of response, and safety analysis. At the data cutoff, median follow, trastuzumab deruxtecan was 20. Next slide, please. We'll come to the next slide. Yeah. So this was the, before we come to the results, this was the baseline characteristics. Most of the patients were equally balanced regarding characteristics. The important point to note here is almost 20% of the patients in both arms had brain metastasis at baseline, and almost 70 to 80, 75 to 80% in both arms had visceral disease also. Next slide. About previous therapies, almost 50% of the patients in both arms were heavily pretreated and had received 3 or more prior lines of therapy. Next slide. So coming to the data, PFS data, which was the primary endpoint, the median PFS with TDX, the trastuzumab deruxtecan was 17.8 months as compared to 6.9 months in the second arm, where was the physician's choice arm. And the median overall survival was 39.2 months as compared to 26.5 months. So this was despite in the physician choice arm, 69.3% of the patients received new systemic anti-cancer treatment, and further on went 25.7% of them went on to receive TDXT in the post-trial setting. So PFS was again superior in all assessed subgroups, including patients with baseline brain metastasis. In baseline brain metastasis, the PFS was 13.9 months with the trastuzumab deruxtecan versus 5.6 months with the physician choice arm. Next slide. So overall response rate with the trastuzumab deruxtecan was 69.7% versus 29.2% with the physician choice, and the median duration of response was almost 19.6 months, which is pretty impressive as compared to 8.3 months only. Next slide. Next slide, please. Yeah. So what about the safety? TDM1, we have got used to TDM1, and I believe most of us are able to manage its side effects properly. So let's see this new drug's safety profile. Grade 3 incidences, drug-related grade 3 side effects, all grade 3 side effects were experienced in almost 50% of the patients. But the important thing is that only 20% of the patients discontinued the drug. The side effects led to discontinuation in only 20%, and that too, the drug-related discontinuation was just 15%. And drug-related death was just drug-related death was just found in 4 patients, that is 1% of the patients. So the most common drug-related side effects, which was the serious side effects, which led to discontinuation, was pneumonitis in 6.2% of the patient and ILD in 3.2% of the patient. So something which we have to be very cautious while using this. We'll have to monitor the pulmonary function test and see the saturation and all. Apart from that, in the physician choice arm, palmar-plantar erythrodysesthesia, most probably due to capecitabine, was seen in 1.5%. Next slide. So this is the list of side effects which was there. Mostly it's GI and hematological. So GI side effects were found in a significant number of patients, especially nausea and vomiting. As far as hematological side effects was there, almost many of the patients did have decreased neutrophils, decreased WBC counts. All of these side effects are easily manageable. So no serious safety signals were observed apart from the pulmonary toxicity. Next slide. So the median onset, the pulmonary toxicity, the median time to onset of this pulmonary toxicity with trastuzumab deruxtecan was 209.5 days. So it has to be remembered that this is a late onset toxicity. And what about the LV dysfunction events? The trastuzumab deruxtecan led to LV dysfunction in 4.5%. Grade 3 only, more than grade 3 was only in 0.5%. So that is more or less similar to TDM1 and trastuzumab. Next slide. Now coming to Destiny Breast 3 trial, where this trial was designed to ensure whether we can move TDXD in up ahead the cycle, but whether it is better than TDM1, which is used as a second line drug or not. So patients with unresectable or metastatic HER2 positive breast cancer were randomized into two arms, either trastuzumab deruxtecan or trastuzumab emtansine. These patients had received trastuzumab in their neoadjuvant setting, and recurrence was within 6 months of treatment. So these patients were basically trastuzumab resistant. So primary endpoint was PFS and secondary endpoint was OS. Next slide. So if we see the baseline characteristics and prior therapies, most of the subsets were equally balanced. Brain metastasis was there in almost 15% of the patients in both arms, and visceral disease was present in 70% of the patients with both arms. And prior treatment, most of the patients had received trastuzumab, pertuzumab. 16% had received, apart from trastuzumab and pertuzumab, some other anti-HER2 therapy also. And median prior lines of therapy in metastatic setting was basically 2. Next slide. So as you can see, the data is really strong. The curves separate very soon after starting the drug and keep on separated for a pretty long period of time. The median PFS was 28.8 months with the TDXD versus only 6.8 months with TDM1. Really very strong data with a hazard ratio of 0.33. Next slide. What about the OS? Again, the curves separate pretty soon, and the distance rises as we go further into the timeline. The median overall survival with TDXD has still not reached, but it is the data is not completely still mature. But I believe TDXD will prove to be superior than TDM1, that is for sure, with a good hazard ratio of 0.64. Next slide. So what about the subgroup analysis? Almost all the subgroups benefited with TDXD, and the main benefit was seen with brain mets group also, which is a very important point to make. Next slide. Next slide. Okay, this is the updated overall response rate. The overall response rate with TDXD was 78.5% as compared to only 35% with TDM1, with a highly significant p-value. And clinical benefit rate was with TDXD was 89.3% versus only 46.4% with TDM1. The median duration of response again was 36.6 months with TDXD versus 23.8 months with TDM1. Next slide. Now, what about the safety? We have got used to TDM1. TDXD, again, the rates of drug-related grade 3 adverse events were similar between both arms, and most common drug-related events which led to treatment discontinuation with TDXD, as was in Destiny Breast 2 trial, was pneumonitis and ILD and pneumonia, respiratory mainly. TDM1 is more hematotoxic, as we all know. The decreased platelet count was there. Pneumonitis was not that significant. Thrombocytopenia was seen in 1% of the patient. So with longer treatment exposure, the rates of ILD pneumonitis increased from 10.5% at interim analysis to 15.2%. So since this is a late onset side effect, we have to be careful when using TDXD. Overall incidence of grade 3 events was 0.8%. It remains unchanged with this updated data. Next slide. So the main side effects which were seen in more than 20% of the patients, as I have said, mostly it were blood related and GI disorders, which both of them are easily manageable with supportive care. Next slide. Now, this is an interesting study. This was a TBCRC 022. This is an ongoing multi-center non-randomized open-label phase 2 trial. This is to see the utility of neratinib in patients who already has pre-existing brain mets. We have the Emilia data, so TDM1 works quite well in patients with stable brain metastasis, that we all know. But can we improve on that? So the only drug which we currently had was lapatinib, which used to cross the blood-brain barrier. Now this trial wanted to show whether neratinib, if combined with TDM1, will provide some added benefit. So the patients were divided into 3 cohorts mainly. Cohort 4A consisted of previously untreated brain metastasis. Cohort 4B consisted of progressive brain metastasis without any prior TDM1. And cohort 4C, the third cohort, was progressive brain metastasis with prior TDM1. So, and these patients were randomized to receive neratinib plus TDM1. Neratinib was given at a dose of 160 milligram per hour once daily. And since the main side effect of neratinib is diarrhea, so diarrheal prophylaxis was mandated during the cycle 1. The primary endpoint was response assessment in BM in each cohort. This is how we see the response assessment in brain mets, and correlative analysis including PROs for GI toxicity. Next slide. So the median, this is the baseline characteristics. So most of the cohorts are again well balanced. The important thing to note here is that in cohort 4B and 4C, which were treated progressive brain metastasis, almost 70% of the patients had received either prior WBRT, CNS surgery, or SRS for the brain mets. So median number of prior lines of CT for MBC was 2. No patients previously had received tucatinib. And next slide. So if we see the CNS response, and the overall response rate in cohort 4A was close to 33.3%. Cohort 4B, which was treated brain metastasis but not received previous TDM1, was 29.4%. And even in those patients who had received the previous TDM1, when neratinib was combined with prior TDM1, the response rate in brain was almost 28.6%, which is quite encouraging. Next slide. So this is again the change in from baseline the CNS response. As we can see, most of the patients had a response when neratinib was added to TDM1. Next slide. So again, this is the probability of overall survival at 12 months. In cohort 4A, at 12 months, almost 83% of the patients were still alive. In cohort 4B, it was 87.5%. In cohort 4C was 83.3%. which is quite encouraging given the seriousness of brain mets in a HER2 positive disease. Next slide. Next slide, please. Okay, what about the safety? As we all know, neratinib causes severe diarrhea. And despite diarrheal prophylaxis, more than one half of the patients had grade 2 to 3 diarrhea. Apart from diarrhea, a significant number of the patients did also have increase in liver transaminases, and GERD was also reported in a few patients. But apart from diarrhea, most of these side effects were easily manageable, and rarely we encountered any grade 3 side effects. Next slide. So to summarize the 3 trials, Destiny Breast 02, TDXD significantly improved PFS and OS compared with physician's choice in patients with HER2 MBC previously treated with TDM1. There was a reduced risk of progression or death. Median PFS was 17.8 months versus 6.9 months with TPC. Reduced risk of death. Median overall survival with TDXD was 39.2 versus 26.5 months with TPC. No new safety signals were observed. Destiny Breast 3, TDXD again demonstrated significant OS improvement with 36% reduction in risk of death as compared with TDM1 in patients with previously treated HER2 positive MBC. OS benefit was consistent across all the patient subgroups, and updated results further support the use of TDXD as second-line standard of care instead of TDM1 in HER2 positive MBC. Next slide. So the last trial, TBCRC trial, neratinib plus TDM1 was associated with CNS activity in patients with HER2 positive MBC who were either previously untreated, as well as those patients with progressive brain mets with or without prior TDM1. CNS ORR ranged from 28.6% to 33.3%. Grade 2 or 3 diarrhea occurred in approximately 1/2 of the patients despite prophylaxis. So that brings me to the end of the presentation. Thank you.
Priyanshi, unmute yourself.
Now let us move on to our third topic, which is hormone receptor positive breast cancer. And for that, I would like to invite Dr. Sameer. He's consultant in Department of Medical Oncology in National Cancer Institute, Nagpur. Thank you, and over to you, sir.
Priyanshi, I will share my slides because I have made some changes, so I want to share.
Yes, sir, you can share it.
Is it visible to all of you?
Yes, sir, you are visible.
My voice is clear, no?
Yes, sir, yes, sir.
Put it on full screen.
Yes. It's already on full screen.
No,
it's okay, sir, right now?
Yeah, that's better now.
So yes, thank you, Samarth, for giving me this opportunity. So after this first talk, I will discuss some of the new abstract which we are discussed in recently conducted SABCS in hormone receptor positive advanced breast cancer. So first, I will start with this important trial, that is Emerald. So Emerald is a randomized open label active controlled phase 3 trial. It has compared the L-Cestrant, which is an oral selective estrogen receptor down regulator, versus investigator choice therapy in patient with hormone receptor positive advanced breast cancer. So in this trial, they have included patient with hormone receptor positive MBC, postmenopausal woman mainly, relapsed after 1 or 2 lines of endocrine therapy, and it should have included CDK4/6 as one of the line. So it was post CDK4/6 inhibitor therapy. This trial was, and patients were randomized to receive elacestrant versus a choice of physician choice of treatment, which can be either fulvestrant, aromatase inhibitor like anastrozole, letrozole, or exemestane. So the co-primary endpoint in this trial was PFS in all patients and PFS in patient with ESR1 mutation, and secondary endpoint was overall survival. So these are the baseline characteristics of this patient, and this was a well-conducted trial, and most of the characteristics were fairly balanced between the two groups. If you see, almost all the patients, that is 100% of the patients, were prior CDK4/6 inhibitor therapy, and almost 50% of the patient received one line, and remaining patient received 2 lines of prior endocrine therapy, and almost 80% of the patient had received prior aromatase inhibitor therapy, and around 20% of the patient also received 1 line of chemotherapy. So now coming to the results. So they divided their primary endpoint PFS by the duration of prior CDK4/6 inhibitor therapy, whether they received CDK4/6 for 6 months, 12 months, or 18 months. And if you see the results, the median PFS was better with elacestrant as compared to standard of care therapy in all the group, that is more than 6 months, more than 12 months, or more than 18 months of CDK4/6 inhibitor, prior CDK4/6 inhibitor therapy. But the in more than 18 months, this numerically it was better, but it was not statistically significant. But for patients with more than 6 months or 12 months of CDK4/6 inhibitor, it was statistically significant also. But if you check by ESR1 gene mutation, so in this group, the benefit was even more. So elacestrant did better as compared to the standard of care therapy in a patient with ESR1 gene mutation, and with a CDK4/6 inhibitor prior therapy for more than 6 months or 12 months or 18 months. In all group, it was better. So this was a positive trial that it has showed a PFS benefit as compared to standard of care therapy. And if you see the safety data, it was a very well tolerated drug. Most of the adverse events were grade 1 and grade 2 only, and there were no grade 4, grade 5 adverse event. Only adverse effect of concern was grade 3 nausea, which was seen in only 2.5% of the cases, and only 1% of the patient required either a dose reduction or discontinuation. That means it is a very safe drug with a very less toxicity. So after this positive trial of elacestrant, we have one more trial of camizestrant, which is another oral SERD, that is selective estrogen receptor downregulator. And this is the SERENA-2 trial, which is a phase 2 trial. And this trial included patients with hormone receptor positive advanced breast cancer who were candidate for fulvestrant monotherapy after recurrence on prior one or more lines of endocrine therapy. And the patient were randomized to receive either camizestrant, which is an oral SERD, versus fulvestrant. Camizestrant was given in 3 doses, that is 300 mg, 75 mg, and 150 mg. The 300 mg arm was closed early, and only 2 arms were continued for further assessment. And the primary endpoint in the study was investigator assessed PFS, and the secondary endpoint was clinical benefit rate at 24 weeks, overall response rate, and overall survival. So now again, as similar to the previous study, this was a very well conducted study. Most of the characteristics were fairly balanced between the 2 groups. But if you see here, the number of overall lines of therapy, most of the patient received only 1 line of therapy. That is 80% of the patient around received only 1 line of previous endocrine therapy. Only 16% of the patient received 2 lines of endocrine therapy, and only 1% of the patient received 3 lines of therapy. And if you see the prior CDK4/6 inhibitor therapy, around 50% of the patient had received prior CDK4/6 inhibitor therapy also. So as in contrast to previous trial, which included all patients were progressed on prior CDK4/6 inhibitor therapy, in this study, only 50% of the patient had received a CDK4/6 inhibitor therapy. And if you see the ESR1 gene mutation status, it was seen in around 30 to 40% of the patient in this trial. So now coming to the results, PFS by investigator assessment. So clinically meaningful and statistically significant improvement in the PFS was seen with both 75 mg and 150 mg of dosing of camizestrant over the fulvestrant in overall population. Even with blinded assessment, the PFS benefit was consistently seen with both the groups. And here we can see the median PFS with camizestrant was around 7.2 and 7.7 months. With fulvestrant, it was only 3.7 months with a hazard ratio of 0.58 and 0.67 with a dosing of 75 mg and 150 mg. So this was again a positive trial. Now, if you see the subgroup analysis, in patient with prior CDK4/6 inhibitor therapy, the benefit was more with camizestrant as compared to the fulvestrant, as compared to patient who has not received prior CDK4/6 inhibitor therapy. This is a very busy slide, so you have to look closely and read the numbers properly. But if you see overall, if the patient has received prior CDK4/6 inhibitor therapy, they did better as compared to patient without prior CDK4/6 inhibitor therapy. And when if you see as outcome as per the ESR1 gene mutation status, so if a patient had a ESR1 gene mutation mutation positive at the baseline, they had a better outcome with camizestrant as compared to the fulvestrant. As in contrast to where if the patient did not had any ESR1 gene mutation mutation present. So that means if a patient had received prior CDK4/6 inhibitor therapy and if they have a ESR1 gene mutation, this drug is going to do better as compared to the fulvestrant. So now coming to the secondary endpoint, that is overall response rate and clinical benefit rate. So if you see the overall response rate, it was better with camizestrant, that is 15% and 20% versus only 11% with fulvestrant. And even if you see the clinical benefit rate at 24 weeks, it was better, that is 47% and 49% with different dosing as compared to only 38% with the fulvestrant. So that means camizestrant improves the overall response rate also and clinical benefit rate also over fulvestrant at as a secondary endpoint. So coming to the safety review. So if you see grade 3 and more adverse event as per the CTCE, if you see this table, only 1 to 2% of the patient had grade 3 or more adverse event similar to the fulvestrant, and treatment adverse event leading to dose reduction and interruption was also very less. So dose reduction required in only around 14% of the patient. Dose interruption was required in only 14% of the patient, and dose interruption was only seen in 9 to 10% of the patient. So that means this drug is very well tolerated and it has a very less toxicity, and very few patients may need a dose interruption or dose reduction. So these are some of the side effects which were seen with these two drugs in this trial. So now coming to the important trial, that is STIC-CTC. So this was a very interesting trial. They have tried to find out whether the CTC driven treatment versus investigator choice treatment in hormone receptor positive advanced breast cancer is better. Means what they have done in this trial, this is the randomized non-inferiority trial. This is a phase 3 trial. So what they have done, they included patient with postmenopausal woman with newly diagnosed hormone receptor positive metastatic breast cancer, and they have randomized the patient into two groups. Either investigator choice therapy, which can be either endocrine therapy or chemotherapy, or experimental arm had patient receive treatment as per the CTC count, that is circulating tumor cell count. If the patient had a CTC count more than 5, they were considered for chemotherapy. If the patient had a CTC count less than 5, they were considered for endocrine therapy. In a experimental arm, in a standard arm, they received chemotherapy or endocrine therapy as per the physician discretion. So if the patient received endocrine therapy as per the physician discretion, they were considered as clinically low risk. And if they received chemotherapy as per the physician discretion, they were considered as clinically high risk. And they tried to find out whether if you select the therapy as per the CTC level, or whether if you consider clinical judgment, whether the PFS is similar, that is non-inferior, or whether it is inferior. And they have reported the current analysis report updated PFS with 87% maturity, and for OS 50% maturity, and pre-planned subgroup analysis was done. So now these are the baseline characteristics. Here, one thing which I highlight here is that in CTC driven arm, that is 377 patients were included in CTC driven arm, and out of that, with a CTC low, that is CTC count less than 5, around 63% of the patient received endocrine therapy, and CTC high, that is CTC level more than 5, around 36% of the patient required chemotherapy. And in the standard arm, that is 378 patient had a where in the standard arm. So in that, if you see the clinically low risk group, that is as per the physician discussion, they were considered for hormone therapy. It was 72%, and clinically high, that is as per the physician discussion, they were considered for chemotherapy. It was 27%. If you compare these groups, so there was almost 60% concordance between the treatment line in the both the group, and there was 40% discordance if you select the CTC rather than the physician discussion. And in the physician discussion, the choice of chemotherapy and endocrine therapy was as per against the physician choice, and mostly it included the aromatase inhibitor therapy or fulvestrant, and CDK4/6 inhibitor at that time was not approved, and that's why it was not given to the patient. And chemotherapy choice was paclitaxel or capecitabine mainly. Now, if you see the PFS and the OS, so if the patient has received treatment as per the CTC recommendation, that is less than 5 or more than 5, or if the patient has received treatment as per the physician discussion, there was no significant difference in the PFS. So if you see the CTC guided therapy, median PFS was 15.7 months, and in the standard treatment it was 13.8 months with a hazard ratio of 0.94, crossing the mark of unity. And you can see here the curves are almost overlapping each other, and similar to the OS also. The OS with CTC arm was 51.3 months versus standard arm, that is 45.5 months with a hazard ratio of 0.85, again crossing the line of unity, and both the curves are overlapping with each other. So that means that trial has made a non-inferiority and has been demonstrated with the use of CTC as a marker for selecting the therapy in terms of both PFS and OS. So now if you see the survival results as per the if you see with endocrine therapy in clinically low and CTC low category, so if a patient has clinically low risk and CTC low risk, and if they received endocrine therapy, again the PFS is similar in both group, and even OS is also group. So that means if the patient is having clinically also low risk, CTC is also low risk, that is less than 5, if you give endocrine therapy, they are likely to do similarly. So now if you see the patient is clinically high risk and CTC is also high risk, which accounted for around 13.2% of the population. Again, they both the curves are overlapping each other, and there is no significant difference. But if you see the discordant group, that is, if the patient is clinically low risk but CTC is high, so if this patient received CTC directed therapy, they had better results. So if you see the PFS here, in a CTC directed group, it was 15.7 months versus standard group, that is 10 months with a hazard ratio of 0.65. And even OS, if you see here, it is 15.8 months, 51.8 months versus only 35.4 months in a standard group with hazard ratio of 0.53. So what we can take from this, if the patient is clinically low risk, but if the CTC is high, that is more than 5, you should try to treat them with the CTC scoring with the chemotherapy rather than the hormone therapy, so that you can have a better PFS and OS. So again, in a clinically high risk and CTC low, so if the patient is considered to receive chemotherapy by physician discretion, but CTC is low, less than 5, again in this 13.6% group of patient, there was no difference. So in that case, we can say in a case where we considered patient to be means high risk, and we considered them clinically to give chemotherapy, but if the CTC is less than 5, you can again treat this patient with or endocrine therapy, and you can avoid chemotherapy, and you will have similar outcome. So now coming to the next trial, that is right choice. So we have been discussing many times, means a few last few years, whether a patient with visceral crisis can be treated with CDK4/6 inhibitor, and there were a few retrospective studies which have shown even in visceral crisis, CDK4/6 inhibitor can be considered, and they can have a good outcome. So this was the first randomized trial. They've included patient with pre and perimenopausal woman with a hormone receptor positive advanced breast cancer in a visceral crisis, and they were randomized the patient to receive CDK4/6 inhibitor with ribociclib and aromatase inhibitor versus investigator choice chemotherapy, which can be either docetaxel, capecitabine, paclitaxel, gemcitabine, or capecitabine, vinorelbine, and treatment was continued until their progressive disease or death. So primary endpoint of this study was PFS, and secondary endpoint was time to treatment failure, overall response rate, clinical benefit rate, and overall survival. So in this study, what they have found that even in patient with visceral crisis, if you give the CDK4/6 inhibitor, they're likely to do better with a median PFS of 24 months with ribociclib and endocrine therapy, as compared to only 12.3 months with chemotherapy, with a hazard ratio of 0.54. And if you see time to treatment failure, it was significantly better with CDK4/6 inhibitor and endocrine therapy, that is 18.6 months versus only 8.5 months with the chemotherapy, with a hazard ratio of 0.45. So even in visceral crisis patient, if you treat them with the CDK4/6 inhibitor and endocrine therapy, as compared to chemotherapy, they are likely to do better and likely to have more benefit. If you see median time to treatment failure, it was median time to response. So it was 4.9 months with CDK4/6 inhibitor versus 3.2 months with chemotherapy. So even time to response was not as such delayed with CDK4/6 inhibitor therapy as compared to the chemotherapy. And even the response rate and clinical benefit rate was better with CDK4/6 inhibitor as compared to the chemotherapy. So again, this was a positive trial. As we all know, the majority of the patient with CDK4/6 inhibitor, the major concern is the myelosuppression, which can be seen in many patients. Like here, it was neutropenia, leukopenia, and anemia was one of the common side effects in with CDK4/6 inhibitor. But if you see other side effects like transaminitis, nausea, vomiting, diarrhea, fatigue, alopecia, it was significantly less with CDK4/6 inhibitor as compared to the chemotherapy. So if you manage this myelosuppression well with CDK4/6 inhibitor, these patients with visceral crisis are likely to do better in terms of PFS also, time to treatment failure also, and they are likely to have lesser toxicity and better quality of life. So coming to the last trial, that is Capitilo. This trial is again a randomized phase 3 trial which has compared capivasertib with fulvestrant versus placebo in AI-resistant hormone receptor positive advanced breast cancer. So we all know capivasertib is an oral AKT inhibitor, and it has shown some benefit in phase 2 FACTRAN trial, and this was again a phase 3 trial which was done to confirm the results of phase 2 trial. So they have randomized the patient with a pre and postmenopausal woman with hormone receptor positive advanced breast cancer who were recurred on or less than 12 months of end of adjuvant endocrine therapy, or in a patient with MBC if they progressed on ongoing aromatase inhibitor therapy, and less than 2 lines of endocrine therapy and less than 1 line of chemotherapy. And patients were randomized to receive capivasertib and fulvestrant versus placebo and fulvestrant. So primary endpoint in the study was PFS, and the secondary endpoint was the OS. And another endpoint was PFS in patient with PIK3CA, AKT, and PTEN alteration. So these are the baseline characteristics of the patient. If you see here, any AKT alteration, that is AKT pathway alteration, was seen in around 40% of the patient in both the group, and AKT pathway was not altered in the remaining percent of the patient. And most common type of mutation, most common mutation causing AKT alteration was PIK3C mutation. Other mutations were AKT mutation only or PTEN mutation only. And if you see the prior CDK4/6 inhibitor therapy, around 70% of the patient had received prior CDK4/6 inhibitor therapy in this study. So now coming to the PFS, if you see the median PFS, it was better with capivasertib and fulvestrant versus placebo and fulvestrant, that is 7.2 months versus 3.6 months with a hazard ratio of 0.60. So that this is again a positive trial. And if you see again, investigators PFS in AKT altered pathway population. So again in AKT pathway altered population, the PFS was better with capivasertib and fulvestrant versus placebo, that is 7.3 months versus 3.1 months with a hazard ratio of 0.60. So study met its dual primary endpoint, showing the significantly prolonged PFS with capivasertib and fulvestrant versus placebo and fulvestrant in the overall population also, and AKT altered population also, with a significant benefit. So if you see this forest plot, almost most of the patient had benefit with capivasertib, whether it is a liver metastasis present or not, whether there is a visceral met present or not. and whether patient has received prior CDK4/6 inhibitor or not. So almost all the group of patient had a better outcome with capivasertib as compared to the placebo and fulvestrant. So even if you see the response rate was better with capivasertib and fulvestrant as compared to the placebo and fulvestrant, with a overall response rate of around 22% in the experimental arm versus only 12% in the placebo arm. And even in AKT pathway altered population, it was again better, 28% versus only 9%. So even overall response rate favored capivasertib arm versus the placebo arm. Now coming to the OS, if you see the OS was again better with the capivasertib arm with a hazard ratio of 0.74, and even in AKT altered population, OS was better with hazard ratio of 0.69. So even OS was overall survival was also benefit was also seen in this study with the capivasertib. So these are some of the safety data, and again it was a very well tolerated drug. There were only few adverse events leading to the death, only 1%, and treatment discontinuation because of adverse event was seen in only 13% of the patient in capivasertib group, and there were no as such new side effects or any grade 4 events related to capivasertib was seen in this new this phase 3 trial, and it was very well similar to the previous phase 2 trial. So this is the same thing, toxicity profile, which can be fairly managed with a proper monitoring and treatment. So now coming to the summary. So I have discussed 4 trials. That is, first is the Emerald trial. So Emerald trial has shown us longer duration of prior CDK4/6 therapy correlated with the longer PFS with subsequent LSS strand as compared to the standard of care, especially in patient with ESR1 gene mutation, with a median PFS of 8.6 months versus only 2.1 months with LSS strand and standard of care respectively for patient with ESR1 mutation, and those who have received more than 18 months of prior CDK4/6 inhibitor therapy. In Serena 2, we have seen camizestrant has associated with a better PFS benefit over the fulvestrant in a previously treated postmenopausal woman with ER positive advanced breast cancer. Camizestrant was well tolerated at both the doses, and there were very few grade 3 adverse events, and very few patients required dose reduction and discontinuation. So in STIC-CTC study, it was the first prospective trial which has supported the clinical utility of CTC count in a hormone receptor positive breast cancer patient for a CTC low and for a clinically low risk and CTC high risk patient receiving chemotherapy had a better outcome. So that means if the patient is clinically low but CTC is high, we should consider them for chemotherapy. You can have a better PFS and OS with that. In a patient with a clinically high risk and CTC low risk, in that group, with the CTC recommendation, if you treat them with the endocrine therapy, they're likely to have similar outcomes. So we can avoid chemotherapy in this group. So that means in CTC selected population, we can tailor our therapy as per the CTC level. In the right choice study, this was the first prospective demonstration of PFS benefit with CDK4/6 inhibitor with endocrine therapy as compared to the chemotherapy in a hormone receptor positive breast cancer, even if they have a visceral crisis. So that even if that means even if the patient is having visceral crisis, we can treat them with the CDK4/6 inhibitor therapy other than giving chemotherapy. And last one is the Capitol trial. In this trial, it was shown that in a patient with previous aromatase inhibitor resistant disease, hormone positive breast cancer, if you treat them with a capivasertib and fulvestrant, they are likely to have better PFS and overall survival also as compared to the fulvestrant plus placebo. And this PFS benefit was across all groups, including patient with prior CDK4/6 inhibitor therapy or a patient with liver metastasis also. So I will end here. Thank you.
It was a very nice presentation by Dr. Sameer. Thank you so much for that. Now let us move on to our next session, which is a practice discussion, which is going to be moderated by Dr. Ashok Vaid. And now I will invite our panelist, Dr. Chakor Vora. He's consultant in Department of Medical Oncology. Dr. Murtaza Bhora, consultant in Medical Department in Medical Oncology, National Cancer Institute. Dr. Akhil Kapoor, Associate Professor in Department of Medical Oncology. Dr. Sameer, consultant in National Cancer Institute, and Dr. D.G. Vijay, a senior consultant, Department of Breast Cancer and Thoracic Cancer Services in HCG Cancer Center, Ahmedabad. Thank you, and over to you, Dr. Ved.
Thank you, Priyanshi. And my job has been done largely by the presentations. And I have drawn out some observations and some questions emanating from these very lucid, very excellent presentations over the last about an hour or so. And as I said in the beginning, that some of them are practice changing. And indeed, let me begin with the first presentation which Akhil had made. And this was on the early breast cancer Monarch E adjuvant CDK4/6 inhibitors. And obviously, the data is so compelling. And there is a large window which has been provided in the recruitment of these patients, and up to about a year plus. I think that's something very exciting for the clinicians, So you don't miss the window. There is a huge window. So let me begin the discussion. Akhil, I'll come back to you for your comments once again. But let me begin with Dr. Chakor Vora. How would you, look at it? And the high burden is something we Indians are so used to. So, and then leave the price point and everything aside. How about science? How robust and have you started looking at it or already started prescribing in that setting, Dr. Vora?
Yeah, thank you, sir. So basically, yes, the as you mentioned, the data is so strong, so robust, and it is compelling to use this particular drug in the adjuvant setting. And yes, I have prescribed it for 2 patients. One is still thinking about it. She's completed her adjuvant treatment, adjuvant radiation, and all. And thankfully, we have 1 year gap, 1 year time period to initiate this one. So I've started her on the AI, and I'm waiting for her to give her consent for abemaciclib. The other patient is waiting for getting approvals.
You've lost your audio is gone. Sorry. Dr. Chakor, your audio is not right at the moment. I think it's frozen. Yeah. Are you there?
Yeah. Am I audible now, sir?
Very well. Very well.
Yeah. So I was saying that I have prescribed it for 2 or 3 patients. 2 of them, one they are waiting for the, like, I'm just waiting for the approvals or.
So it is already a practice changing trial in your the data in your personal practice.
Definitely, sir.
So
Definitely.
Dr. Murtaza, Akhil did make a mention about the incidence of diarrhea, and we saw presentation after presentation, a lot of international speaker presentations happening in India, and the concern was diarrhea, and so many case scenarios were constructed of elderly, being living alone, and should we prescribe this drug to them, and then how do you react to the observation of Akhil, to which I fully agree. Diarrhea has not been an issue in our practice, and our experience with the drug has been quite a bit now, and we are not really concerned about the diarrhea. So, Dr. Murtaza, your comments on.
Yes, sir. Diarrhea is an issue, but in my thought, it is well manageable because now we have like loperamide and Lomotil, other agents with us. So not very grade 3, grade 4. We have seen that the grade 1, 2 grader is quite common with abemaciclib. So, and especially in young patient or middle-aged patient, they very well tolerated this. Slight issues with very elderly patient. So we will think about it, and if the patient is very frail or like as you mentioned alone, then it might be some issue. But is in the adjuvant setting, I will definitely keep in mind that the Ki-67 value is also in my routine practice. If it is very low, then I will think about using this drug. Otherwise, in all other setting high risk features, I will definitely use.
Perfect. Akhil, now I come back to you. The approval to the drug internationally is based on one of the parameters is Ki67. But in India, the DCGI has disregarded that. Do you think that's a good point to have, because the standardization of Ki67 in India and a lot of labs still struggling with that? So was it a good point? Node positive, larger tumor, regardless of Ki67. What's your comment on that?
Yes, sir, I completely agree. As you mentioned, Ki67 is highly subjective. Different pathologists might have different opinion on the same tumor. It might be regarded as 15% by one and 25% by another. That will change the approval of the drug. So any patient who is a high grade and multiple node burden is high, I won't see Ki67. Ki67 is prognostic but not predictive of response also. That is also which I've highlighted in my talk. In very small tumors, I don't think these drugs will give a lot of benefit. So I restrict my users to mainly in patients who are heavy nodal burden positive, because we know that these will relapse fast.
Node positive. Yeah. I think that's a very valid point, and it was a very progressive type of an approval by the DCGI disregarding the Ki67, because it would have created a lot of confusion in the Indian setting. Actually, Dr. Vijay, you're hearing now in the adjuvant setting, from the days when we used to do surgery followed by radiation and followed by anything else. We are seeing this practice shift from the basic tenets and basic principles stay same. How, as a surgeon, are you, viewing all this change, that the hormone therapies, CDK4/6 inhibitors coming into the adjuvant setting, and so much revolving around that? Dr. Vijay, are you there? Anyway, we'll come back to you, sir. So also, I actually wanted to touch upon some of the neoadjuvant stuff as well, but we'll come back to you, sir. Now let's move on to the next section, and about the issue of pregnancy, and we do come across younger women who come to the clinic, and it's a huge discussion. Medical oncologists till now were struggling to give any strong data points or give strong sort of published literature, published literature. So this trial actually brings out probably one of the key points in the clinical setting, that there can be an interval where a lady could stop the drug and plan a pregnancy. And Dr. Sameer, how excited are you with this data, and how empowered do you feel as a medical oncologist now to go back and quote all this to your and do you still accept that some of these recurrences which would happen are acceptable recurrences? So let me repeat two parts. How empowered do you feel, and your comment take on the recurrences which would happen in the interim period?
So basically, I've seen that abstract. Means most of the cases generally means whatever we have seen in our area. Whenever we see a girl of means maybe a female of 35, 40 years old diagnosed with CA breast, they are mostly married. They have one or two means like already daughter or son they have. So very rarely we come across a patient unmarried and diagnosed with CA breast, and then we have to plan a therapy. In that case, we generally counsel them for fertility preservation and something like that. So that like ovarian tissue preservation or ovarian, like you can say oocyte preservation. In a case where patient has been treated, this comes when the fertility preservation has not been done, and patient has received treatment and now she wants to conceive. So we don't have any oocyte preservation or any what we can say ovarian tissue preservation which we can utilize. So in that case, this situation will come. So this will be a very rare scenario, and even the data shows that patient can undergo pregnancy, but I again will be slightly hesitant explaining the patient we have to stop therapy, and that is always after the counseling and the patient is very much keen and they are willing to take the risk of recurrence, then only. Otherwise, not for every patient.
Very well. And Akhil, Sameer has touched upon a very pertinent point, that oocyte preservation or the ovarian function preservation, different strategies. Now, will it give the leeway to medical oncologists to give up the cumbersome fertility preservation procedures and upfront counsel the woman, a 30-year-old lady who's married just about a year and a half back, and obviously desires children. So would you, as a medical oncologist, sort of counsel upfront that there is a strategy now?
Yes, yes, I completely agree with you and Dr. Sameer, sir. So actually, oocyte preservation, it was so complex that actually in real practice, we have seen one or two patients only in the entire telomere small carrier. But it's this data will give me more confidence, and it will give some medical legal support to us as well. That if we forgot to counsel about the ovarian preservation upfront, this will also give us some more power even in the court of law. So that seems to be useful. But yes, we will still continue to counsel whenever feasible, but at the same time we'll quote this data that yes, it is feasible after that also.
Thank you so much for bringing out that point. It's an excellent point that now medical oncologists can fall back upon published literature, and in case of any legalities, during the course of the treatment. Now, Dr. Vijay, if you're back, then I could. Okay, so Dr. Murtaza, let's now move on to the next section. We were discussing about, and Dr. Kumar Saurabh had presented about the HER2 new data. Now, TDXT versus TDM1. It's a very interesting debate which has come up now. And we knew that TDM1 is the next line of treatment once there is a failure on the frontline treatment. So, do you think that TDM really would stay, with the TDXT, again leaving the cost aside, and the robust science the way it is? So, first line failure, you think TDXT is really the new standard from the data, from the Destiny 3 data?
Yes, sir. If we see the data is quite robust. So, and one main important point of TDX is it acts on HER2 low also. That's why if there's any HER2 heterogeneity in the tumor, so we have seen sometimes HER2 positive patient also fail earlier on trastuzumab or anti-HER2 directed therapy. So in TDX, this is really the important for me that if it works on the HER2 low also or HER2 heterogeneity. So I want my patient to do the best one upfront. So in subsequent line, I will definitely go with TDX if cost is not an issue with the patient. With this robust data, definitely I think everyone else in the future definitely go for the TDX.
Excellent point about the HER2 heterogeneity, and I would like to go around the table once again and have comments from Dr. Chakor, Akhil, and Sameer. Quick comments, because we still have a lot of discussion to come by, and we would like to take the discussion forward. So, Dr. Chakor, about the tumor heterogeneity and how difficult or important is it for the practicing clinicians?
So apart from the cost, sir, I also agree that yes, TDX is the way ahead. And he rightly pointed out, Dr. Murtaza has already pointed out it. So I completely agree with him, sir.
Sameer? Akhil, I can see you.
Yeah. So yes, TDX has shown excellent responses in most of the scenarios, even in HER2 low. Yes, in such scenario, more data will be required. But yes, we know TDX is going to work in most of the scenarios because of the excellent potency of this drug.
We saw the forest plot where everything was to the left, and to the left of the unity, and probably very robust data. What about the brain mets? Brain mets is a significant issue in HER2 new positive disease. Are we as secure with the? I wouldn't say as secure, but are we more secure with the TDXT?
Yes, yes. I have already utilized TDX in patients with brain metastasis and gives so fast responses. It was unbelievable. The patient was having a lot of symptoms. She was not fit enough to lay down for radiation. The radiation colleague refused for giving whole brain radiation, and I started TDXD, and the patient was so well after 15 days of starting infusion that that further treatment was feasible. So this is one of the drug which has magical responses. Hopefully, more of us and I will be able to utilize in more and more number of patients.
Excellent. Thank you so much for sharing your experience. And Dr. Vijay, are you there? Can you hear me? So I'm just looking at the timer also, so we still have enough time. Now, in the HER2 new positive disease, these patients would continue to recur once we know it's an inexorably recurrent disease. Is there data beyond TDXT, or is it only a TPC, the treatment of physician's choice? So where do we go once the TDXT failures would happen? Because everybody is not going to respond to the drug, and then there would be some non-responders upfront resistant and subsequent relapses. Is there data? I think Kumar had presented TDXT, but maybe anybody can take up this, whoever wishes to take up this question.
Sir, I think tucatinib has also a good role if the brain mets is there. So if the patient fails after TDX in brain, if we see like the most century side, so we can use tucatinib. So and otherwise, trastuzumab we have to re-challenge with the trastuzumab some other chemotherapy together. That's where we have.
Very well. So Dr. Vijay, once again, I'm reaching out to you. Can you hear me? I'm not able to get a response from Dr. Vijay. Anyway, let's move on. Now the hormone receptor positive advanced breast cancer. So there is a lot of buzz now about the oral drugs, and we have the oral ADT, we have the oral drugs as far as the estrogen receptor downregulation is concerned, and the two drugs that elacestrant and camizestrant. I think these two drugs are going to shape the future, and nobody wants to. But if you ask your patients on fulvestrant, and everybody is fed up of those injections, on a monthly basis, and people do have concerns in terms of the local site injection trouble. Now, my point is not from the tolerability or the logistics part of it. My point is actually from the ESR mutation status. So should we start actually doing the ESR for most of our patients in the upfront setting, learn about it, and therefore we may have something to do with the ESR mutation once we choose the drug, or the partner drug. So any comment on that, Akhil, or anybody else can?
Yeah. Science-wise, definitely it seems that if we are having ESR1 mutation status, it will help us in choosing the drug in the first line setting. But seeing the status, ESR1 mutation is not so common in the first line setting. Though PIK3CA mutation status is quite static, but ESR1 mutation status is slightly dynamic, which I have found in our practice as well. For example, when I did an NGS at the baseline, ESR1 was not there, and at progression on letrozole plus ribociclib, I found the ESR1 mutation. So it might be some like dynamic action, but yes, science-wise, it is perfect. If you have ESR1 mutation, definitely would like to start with a drug like fulvestrant.
And the choice of a down regulator. Would you choose a down regulator first, or still reserve for a later line?
No, if ESR1 mutation is there, sir, definitely I will try to start with the most effective drug, because whatever you do, if a patient progresses on the first line treatment, there will be at least some amount of dropout for the second line. For example, 10 to 20%, even in this scenario, will be there.
Excellent. The next presentation was on the CTC.
Sir, I just want to comment. Sorry to interrupt.
Yes, please.
Totally agree with Dr. Akhil that we know the PIK3 is from day one, or we can use it on test on the archival tissue only. And ESR1 is the acquired resistant mainly because of the AI or any hormonal agent. So if, and it's a prognostic value also. ESR is having the bad course of the disease. So if we know early that the ESR1 mutation is present, we can use the drug which act on more on ESR mutated scenario. So we have we can, I think in the future we see the overall survivors also with more with the agent which more act on the ESR1 mutation. So definitely it will change our future deciding options if we have upfront ESR1 mutation positivity.
And also about the convenience.
Yes, oral and injectable, definitely.
So let's come to the next paper which was presented, and this was on the CTCs. Interesting story of CTCs coming into breast cancer as well. We know there has been a lot of work, background work, but how to harness the CTCs we didn't know. And obviously one of the limitations, and which I would request Dr. Sameer, are you there?
Yes, I'm here.
So the trial was actually, the trial data is the pre-CDK4/6. Would this data really
Yes,
still...
sir. It was conducted between 2010 to I think 16, 15, 16, something like that.
Absolutely.
So it was a long trial. It took a long for trial to complete.
So the standard of care has shifted. So
Yeah.
So what do we make out of this? You have
see, sir, means
with the data very extensively, but in short, will this trial actually drive the decision making still?
See, sir, in the next trial which I have discussed in visceral crisis patient, where generally we consider clinically high risk for chemotherapy. Even in that scenario, the means hello. Even in that scenario, this hormone therapy is working well. CDK4/6 inhibitor therapy is working well. So in a case where we think clinically patient is high risk, but CTC is low, even in that case, your hormone therapy is working well. So in a case where the patient is clinically low risk, but CTC is high, only in that case, in that small group of patients, they have shown that chemotherapy may be better. But I may not change my practice right now based on this data.
That precisely is the point of discussion, that even in that group, what about CDK4/6 and one of the hormonal agents?
So that was not given. So that's why I think this trial just gives us a benchmark for future studies which may be conducted in a better manner. But I don't think it is practice changing right now.
Excellent. Dr. Chakor, your views on that?
So I agree with that part, that yes, it is not practice changing presently, but also we should probably look at it that yes, we are looking at some a different marker which will be helpful for predicting responses or predicting progression. Just as they have shown in the trial, that the patients who had a higher percentage of CTCs, they were more likely to respond to it or more likely to progress. So maybe that we can, as Sameer also suggested, we can implement, or it can be tried out in another way or in a better trial here onwards. And maybe the next study which comes up, that may help us in using this particular CTCs in decision making later on, but not now.
Akhil, let me ask you a very provocative question. The takeaway from this trial probably could be that are we looking at a new stratification point for the MBCs? Hormone receptor positive, CTC less than 5, more than 5, whatever it is, 1.5 per ml. That's what I put. Is that a new stratification we are learning through this trial, or more work still needs to be done?
Definitely, sir. A lot of work needs to be done, but this is definitely a strong hypothesis generating study. So yes, if in the future studies this strategy is kept, I think they will be able to find some more answers. And yes, I completely agree with you, sir, that this is going to be a next game changer. It had already changed the game in colorectal, and hopefully this will change later in this scenario as well.
So Dr. Meenu, by any chance, are you there? No. So I couldn't get Dr. Vijay still. Is Dr. Vijay available? Now the next interesting story is the capivasertib. You know, these are the tongue twisters. So sorry for I'm sure everybody struggles with them. So, and the AKT story. Now we haven't talked of AKT in breast cancer. Yes, we were up to the hormone receptor positive, PIK3, and HER2, the biomarkers were not very many. So this opens the door to, and then we know the AKT PIK3 pathway actually is a very interesting, is almost like a, you know, the controlling pathway or the controller out there. So is this a new sort of a shift in our the understanding, and the second is the drug development? So quick comment from each one of the panelists. So whoever takes it first.
So I will go ahead. Yes, sir. Definitely, this seems that a specific AKT inhibitor, which is, for example, capivasertib, it has changing the way we will treat AKT patient, because everolimus has some activity, but it is having so many side effects, and it's not a specific inhibitor. So yes, we are looking at the same, and we have capivasertib trial at our center as well for both breast and prostate cancer, and it seems that yes, this drug has some good activity and patient selection. So we are going towards personalized cancer medicine more and more, finding a proper mutation, adding drug for the same, and continuing the standard of care. For example, it was fulvestrant in this case. So definitely find the mutation, act upon it. That will definitely help in the treatment.
So a new biomarker to select a drug. Dr. Chakor, I can see your video coming on.
Yes, sir. So I'll just like to say that maybe it is, yes, it is a new biomarker. The drug is available, or like through trials, it is available now. But the toxicity seems to be quite high over here as well. The mortality was 1.1%, grade 3-4 toxicities was 16-17%. Discontinuation rate was also quite high, and the PFS wasn't really very impressive. PFS or OS differences were not so impressive. So I think we yes, we need more time, more drugs coming on this pathway or coming on this target also. So maybe Akhil is, so he may be able to tell more about the toxicity.
Toxicity, if you could enlighten us more about the toxicity.
Yes, sir. So this is reminiscent of the Bolero trial era, where we saw a lot of toxicities, hyperglycemia, and apart from some HFS as well, apart from transaminitis. Yes, the drug is toxic, but even with capmatinib, which is a MET inhibitor, completely different, we see a lot of toxicities. 50% patients have grade 3, grade 4 toxicities even with capmatinib, and that is a very well accepted care of treatment in a specific mutation. Similarly, here, if we found the mutation, yes, we will learn how to manage the toxicities with time, and then it will change the game. For example, TDXD, it caused 5% mortality in the initial trials. Now the mortality will come down to 0%. This is the way we learn science, and with time we'll know how to manage the drug. For example, simple example of dacomitinib, everyone uses 45 milligram, but if you start 30, nobody will have so severe toxicity. Similarly, I think this is the way we learn science and manage the drug.
So I think medical oncologists live with toxicities, and they get smarter over a period of time with each drug. I'm totally in agreement with all of you. Dr. Chakor, any comment on that? So any other points regarding? I think we are now closing down on our time allocation, and we are half an hour into the discussions. So if none, I take this opportunity to thank all the panelists. Wonderful discussions, great insight, scientific, personal, enriching the discussions. Thank you, everyone.
Thank you, sir.
Thank
Thank you.
Back to Priyanshi for you to continue the proceedings.
By Dr. Ved, and thank you so much, Dr. Ved, for that. A very delightfully moderated by Dr. Ved. Thank you so much to all the panelists, and thank you so much, Dr. Ved, for moderating the session. It was a great panel. And now let's move on to our take-home message. And I would like to invite Dr. Meenu Walia. She's Senior Director in Department of Medical Oncology, Mac Super Specialty Hospital. Over to you, ma'am.
So thank you, Priyanshi, and thank you, Dr. Ved, for the invite. I will rather stations and the panel discussion by Dr. Ver, and I really don't know what is left for me to say. Knowledge is now probably we are where the era of personalized medicine has come. So recognizing that each and every case. So knowing what we saw is also like even visceral crisis is not a criteria now for something like thinking of chemotherapy in hormone receptor positive, HER2 negative. So we have studies that say that even in that group, probably a combination of this CDK4 and hormonal therapies
We're not able to hear you, Dr. Meenu.
is showing almost double the PFS. So the era of personalized medicine is here. And similarly, from the other
I may suggest you switch off
study
your
that
video.
we saw, CTCs, which we have been talking for a very, very long time, now we do realize that how probably it is making clinical sense, technical errors here. So they've talked about.
We can't hear you, Dr. Meenu. You are on mute. Dr. Meenu, you are on mute.
Is it better now, sir?
It's better
Hello?
now. We can hear you. It's better now.
I think there are a lot of, I'm feeling some errors, I mean, some problem in the internet connection at my place. So I would end by saying that personalized medicine is probably the way forward. And all the important trials discussed about adjuvant abemaciclib and about the CTC and how it helps in deciding, and the newer targeted drugs, AKT, probably these targets are in some way practice changing, and in times to come, we will become more confident. I'll end by saying that only. Thank you.
Thank you so much, Dr. Meenu, for such a wonderful message. And with this, I would like to thank all the faculties for joining with us today and for giving such a precise and informative talk on all the topics. And I thank all the live audience who have joined from all across the country, from different countries. And thank you to all the panelists, all the doctors, and thank you so much, Dr. Ved. Sir, do you want to say something?
It's a big thank you to everyone and who's made this program come alive and contributed to the success of this program. That's it from my side. I've already thanked everyone at the beginning, and look forward to another opportunity soon enough. I wish you and your families a very happy New Year and a Merry Christmas. Take care. Enjoy. Thank you so much.
Thank you, sir. Thank you. Good night, everyone.
Thank you.